good luck, everyone. You'll be fine. Thank you. And we know the order of events. Thank you. We'll just give them a few more seconds to join.
Well, the number of participants is increasing.
Yeah.
Yeah.
As of course we all know, it's not just the participants, it's the many, hopefully the many thousands who will watch this again and again in years to come. The series on this good subject. So I'm grateful.
That's extremely comforting.
Yeah, indeed, Marianne.
Well, I'm sure you'll enjoy the day. Thank you very much for logging in. I really appreciate it.
We will be hunted by it.
I'll just give them another few more seconds and then we'll I'll introduce you all. Okay, let's begin. Okay, welcome to everyone. Welcome to the panelists and to all the EANS members who have kindly tuned in, and to all the audience that will watch this later on. It's an honor to be able to introduce the panel. Before I do, just wanted to say a big thank you to the EANS who have been very positive and supportive of the CSF task force. And we've heard the good news that this is set to become a section later this year. And we're all very excited about that and being together, hopefully in Belgrade, and selecting officers and voting for people to take this movement forwards. One of the visions that core members and panelists had, and I remember talking about this to Marianne years ago, I think it was in Dublin, was improving the education and awareness regarding core subjects to do with the CSF specialty. And perhaps there is no better one than familiarity and increasing our knowledge regarding CSF diversion use of shunts. I can't think of another better operation in neurosurgery which has saved more lives than shunts, than CSF diversion. And perhaps the most common subspecialty there is this one. And this is certainly one of the foremost procedures. So with that in mind, it's been a project to improve the education and awareness, and particularly as the number of devices is increasing, their complexity is increasing, and their brilliance and efficiency, as well as lower complication rates, is improving all the time. We need to increase our awareness and our expertise. So we can't think of really better group of people to introduce, really. And so I'm very grateful to Ahmad Amar, who's been really leading on the hydrocephalus classification and helping putting this brilliant group together. We're all friends. I welcome Ahmad for chairing this session and taking this forwards, and this will be one of a series of webinars on this subject. So it's the first one, and we're really excited about that. We welcome Marianne Jula, who's been brilliant in this field and needs no introduction, but we're very grateful to Marianne for spearheading this and being here today, as well as leading on the classification project as well. We're internally indebted to the godfather of pediatric neurosurgery, Harold Rackay from the United States. It's an honor to be in the same virtual room as Harold. And of course, to Andre, who's been so brilliant in this field for so many decades, and also needs no introduction, particularly on the EANS educational aspect. So I welcome you all. Thank you, group. And I'm going to hand over to Ahmad to take this forward. Thank you.
Thank you, Mansoor, very much. And thanks for your leadership, which made this kind of webinar is possible. I welcome all the attendees, which we have now around 76. This is a good number to start with. And I will not forget to thank EANS and in particular Anna for her quite well. Now we'll go to the subject. I think this is a part one of our series of maybe 5 webinars to discuss different problems of CSF dynamics and shunt complication and how to use the shunt and how to treat hydrocephalus. We will start. If I give you an idea about the program, we will start with Dr. Harold Reke about CSF dynamic, then followed by Dr. Marianne Jolar, and then Dr. Andrea Grottenhuis will take over and receive the question from everyone, and then we will have a discussion. And we will end with take-home messages from Marianne and from Hal. I am extremely honored to introduce Dr. Harold Reke. Harold Reke is very well-respected pediatric neurosurgeon all over the world. And I think he is one of the very few people who really understand what does it mean CSF dynamic. And we all learn it from him. So I will leave you with Hal to discuss the CSF dynamics. And please, if you have questions, send it to us and we will discuss the question at the end of the webinar. Please, Hal. Hal.
I'm getting there. Am I on?
Yes.
Do you see my slides?
Yes.
Okay. Now, I'm going to get this over there so I can get slideshow. Okay. Well, I'll do it this way. It's my pleasure to open this discussion of the management of hydrocephalus. We will concentrate briefly on biomechanics of hydrocephalus, leading to a discussion of the selection of valves for treatment. My job is to review the normal mechanisms of CSF production and absorption. It will emphasize this function of CSF absorption as a natural shunt mechanism. This natural shunt has developed by a process of natural selection over millions of years. For this reason, the best shunt system would be one that would function in the same way. There are no
Harold, can you just
conflicts.
put on the slideshow?
I did. There it is.
Well,
Keep hitting it, it doesn't do anything.
it is visible, Hal, anyway. So I suggest that you just proceed.
Continue, yeah. Thank you. Sorry about that. There are no conflicts of interest. The discussion relates to both clinical and practice and scientific endeavors to understand hydrocephalus and its treatment over a 40-year career. For this, I am indebted to my mentors and co-workers in engineering who have challenged and inspired me to continue to do so. In 2009, I published a review article related to the definition and classification of hydrocephalus. Over the next 2 years, the concepts were presented to a large number of groups of neurosurgeons, engineers, pediatricians, and neuroscientists to come up with a consensus on these matters. The acceptance of these issues was widespread, but not without some disagreements. Hydrocephalus is an active process with the distension of the ventricles of the brain. With the exception of the rare condition of excess production of CSF related to tumors of the choroid plexi, this condition relates to a restriction of flow from the point of production of CSF within the ventricles and its absorption. In order for the ventricles to expand, there must be a pressure difference between the ventricles and exterior of the brain, which now I will call the mantle. In newborns, and especially in premature babies, the skull is distensible and the volume of the intracranial compartment can expand. The fontanelles and the sutures are open, so the mantle can be seen as between the ventricle and the atmospheric pressure. The skull is not as distensible, the mantle is the brain itself. In this case, transmantle pressure difference is between the ventricles and the cortical subarachnoid space. It should be noted that there is not a significant change of the volume of the brain as the ventricles change size in the process of the ventricles changing size. The brain stays the same volume. The brain itself can be seen as a balloon or a car tire. The balloon will increase in volume when there is a significant discrepancy between the ventricular pressure and the exterior of the brain. In the vast percentage, that relates to the pressure difference between the ventricle and the outside of in the cortical subarachnoid space. This graph relates to the effect of intracranial pressure on the production and absorption of CSF. Production of CSF is independent of intracranial pressure. The absorption of CSF is dependent on the ICP. Please note that there is no absorption of CSF until the ICP reaches 68 millimeters of water, which is 5 millimeters of mercury. Above the threshold, the higher the ICP, the higher the rate of absorption. The 68 millimeter relates to the pressure in the dural venous sinuses in a recumbent position. At 112 millimeters of water, the system is in equilibrium between the production and absorption of CSF. The effect of this interaction is that normal valve functions as a CSF to dural venous sinuses with an opening pressure of 68 millimeters of water, essentially a medium pressure valve. Subsequent research has shown that the absorption of CSF is more complicated. Chronically increased intracranial pressure can result in the development of alternative pathways of CSF absorption. CSF is produced within the cerebral ventricles with some production within the central canal of the spinal cord. Originally, the work by Dandy confirmed that CSF was produced by choroid plexuses. CSF is also produced by flow of extracellular fluid through the ependymal surfaces. Several studies have confirmed that several months after a choroid plexectomy, the CSF rate of production is back to normal, so that we don't know how much the difference between the CSF from choroid plexus and CSF from the brain itself. It is noted that the volume of the brain determines the amount of CSF that can be made from the extracellular fluid. Absorption of CSF is actually somewhat more complicated than production. Based on the subject studies by Dandy in the second decade of the 20th century, the exit of CSF was felt to be a passage through the arachnoid villi directly into the dural venous sinuses. When the villi are actually visible, they are called arachnoid granulations. And it turns out that this mechanism is only part of the process. Arachnoid granulations are not found in humans earlier than age 2 and are not present in many species at all. A significant portion of CSF has been shown to exit first to lymphatics in the dural venous, in the dura itself, prior to finally entering the veins. These two pathways represent the primary source of CSF production. As shown in infusion studies, there are secondary routes for CSF clearance recruited at higher ICPs. These secondary routes include the cribriform plate, the orbit, and the arachnoid around exiting spinal and cranial nerves. These secondary sources of CSF absorption are likely responsible for cases of compensation of hydrocephalus. Recent studies have shown that CSF in the arachnoid space may re-enter the brain and spinal cord within the Virchow-Robin spaces in a process that's been called lymphatics. This process washes out toxins and has been shown to be important, especially in sleep. The amount of CSF, however, leaving in this process is unlikely to be involved in CSF dynamics. The most difficult part of the management of hydrocephalus with shunts relates to hydraulics. When the human stands up, gravity leads to the CSF leaving the calvarium, resulting in the distension of the lumbar theca and decrease in intracranial pressure, which is then negative related to atmospheric pressure. When the patient lies down, the CSF immediately returns to the calvarium, leading to normal intracranial pressure. In the case of a patient with a shunt, the CSF that is lost through the shunt does not return to the intracranial space, and this is what we call siphoning. In a subsequent webinar, the use of devices to prevent siphoning will be discussed in some detail. It is possible to deal with this in a way that is more natural. This strategy would require that the exiting CSF and the venous system be at the same level as the dural venous sinuses. A number of neurosurgeons, including especially Borgeson, have done this by doing ventricle to transverse sinus shunts. And I've had some experience with that with some extra interest, I think, good outcomes. This last one is the present of they've actually been able to do a CSF to sigmoid sinus with purely endovascular techniques. That's I think it's very exciting. In 2019, I published a review article related to the definition and classification of hydrocephalus. And over the next 2 years, it was presented to a number of groups of neurosurgeons and other interested groups to come to a consensus in these matters. The acceptance of this concept received a great deal of acceptance, but there were some skeptics. This diagram envisions the process of CSF being produced from arterial blood to the ventricles and flowing from the lateral to third to fourth ventricles and out into the cisterna magna and eventually be returned to the veins. And when we put this together, it included the dural venous sinuses, the lymphatics, the nerve root sleeves, the olfactory bulbs, transependymal, parenchymal capillaries. It does not include the transpeel modality. I don't think we would see that. As seen in this diagram, the endoscopic third ventriculostomy creates a flow between the third ventricle and the interpeduncular cistern, which is essentially distal cortical subarachnoid space. It bypasses the aqueduct and the fourth ventricle outcome. Even if the ETV is done and the shunt is still needed, I would say to you that it may well be helpful in the management of the shunt that has to be placed. The role of the cortical subarachnoid space is extremely important in understanding hydrocephalus, but is usually ignored. This slide is a mind experiment related to the stacked spheres like Russian stacking dolls. The volume of the sphere is measured by the equation V equals 4/3 pi r cubed. The cubic measurement is really important because small changes in the thickness of the cortical subarachnoid space leads to a great deal of redistribution of the CSF from the cortical subarachnoid space to the ventricle and back and forth. And in this picture, the brain size is the same and the CSF size is volume is the same, but you can see a large difference in what the ventricle looks like. The radiologist almost never will tell you about the change in the cortical subarachnoid space, but I would tell you it's very important when you're dealing with hydrocephalus to look at the thickness of the cortical subarachnoid space. When a shunt fails, the brain does not get smaller. It is always just a change of the volume from the ventricle to the cortical subarachnoid space and vice versa. Now, I think this is one of the most important of these discussions. We don't really look at the fact that the foramen of Monroe is not a fixed orifice. It is distensible. We would look at in our laboratory. The only place we could find a pressure difference between the ventricles and the cortical subarachnoid space and the brain parenchyma itself, the only place we could find a pressure differential was between the right and left lateral ventricle when one of them was being drained. And this is really important because once the columns of the fornix come against the caudate nucleus, there is no flow between the third ventricle and contralateral ventricle into the shunted ventricle, and it will collapse. And I think that's one of the major problems. So we should try very hard to not have complete collapse of the ventricle that contains the shunt. So the presence of difference in the volume of the pressure from one ventricle to the other, it should be mentioned, and it's probably the strongest reason why you should have programmable valves, I think. So Riquet's rules for the difficult shunt. I think that the biggest problem relates to all compartments not being able to communicate with each other, which is the reason I think we should make more use of third ventriculostomies, because it would then allow you to control all of the CSF. If you put a shunt in and there's a block somewhere, or if there's an arachnoid cyst or things like that, you're only going to be, or Dandy Walker especially, you're only going to be able to take out the CSF that you're shunting. And so if you have to have two ventricular catheters to take care of all of the CSF, they have to be seen as the same pressure. And if you have two valves, only one of them will work. The lower pressure valve will open and the higher will not. So you can only have one working valve. So if you have to put two catheters in, it's really important to put them on this that are filling the same valve. So I think this is my take-home message. When there are continued symptoms, and especially if there are multiple shunt failures, the problem is not likely to be the physics of the shunt itself, but it's the problem of the patient. It's really important to look at and figure out what's really going on with the patient. And sometimes it needs multiple catheters, and sometimes it needs endoscopic procedures. I appreciate your opportunity to talk to you today about something that means so much to me. Thank you.
You are muted, Ahmed.
Thank you very much, Har, for this outstanding presentation about the CSF dynamics, which made it very clear and understandable to everyone, rather than it is a very difficult and complicated process. Now we move to the second speaker, Professor Dr. Marianne Johler, the professor and chairman of pediatric neurosurgery in the University of Denmark, and she was chosen actually by the European Association of Neurological Surgery as the best teacher a few years ago. And she is really an educator and a great researcher. She is going to talk about valve principles knowledge. Why we talk about this especially? Because it is true. If you want to use the tool, you have to understand how the tool will function. This is true in industry, true in everywhere, and very, very much true in medical. Please, Marianne.
Thank you very much, Ahmed. I will share my screen. There we go. Share. So, is this visible now?
Yeah, but if you can have full screen.
I'll try. I just did.
Well, it seems there is some problem, maybe anyhow with the setting. Okay, go ahead.
Okay, thank you.
Yeah.
Yeah. So, as you said, I'm going to talk about valve principle knowledge, and I'm going to talk about the very simple basic principles. And the reason why I do this is exactly why it was presented by Dr. Amar, that you need to know a tool in order to use it appropriately and optimally. Also, it is my experience that even the most basic valve principle knowledge is not encouraged, and it's not taught even at trainee courses. So I think this webinar is one of the opportunities to acquire at least some basic knowledge. So my rhetoric questions here are really already answered. Why is it necessary? And I think Hal told us why it's challenging and professionally satisfying. And I hope I can convince you why it is not boring. So I have no conflicts of interest giving this talk. Before we go on, I am afraid that it's not possible to see the top line. Is that true?
We see it. No.
You see it even from number one?
Yes.
Yes. Okay. Right.
So go to the next slide.
No, I will just leave the audience with 15 seconds to read these questions.
No, but we
don't see the question.
We can't.
That's what I asked.
No.
Marianne, can you actually try once again to press on slideshow?
No.
I did. I already did.
Yeah, that's one of the problems. Go out of the slideshow and just proceed. There is some kind of technical difficulty.
Yes, there is. I will try.
Yeah.
Okay.
Share it again.
Share.
Yes. And then just keep out of the slideshow and just move on the left side your slides one by one. This is the, so this would be slide number.
Okay.
These are the questions now.
I can do this, yes.
And we want to have all the, well, I see it is now 113 participants to indeed think about these questions as a kind of self-assessment, so that you really start to consider for yourself if you are capable of understanding these principle of SHUNTS.
So this is self-test questions for just 15 seconds for everybody to read and think about.
Mm-hmm.
Marianne, forgive me. Do you think you could press the full slide button and then lower?
Mansoor, we tried that, and
we tried
already with Hal, and also when I tested it, somehow we see it then on our own laptop that it is a slideshow, but apparently it doesn't show up in the Zoom. There is some kind of.
But Marianne tried it before and it worked.
Yeah.
Oh, yeah. Okay, I think everybody's had a chance to look and self-assess the question, so I think we'd better go on, and I'll try and see how does that do. So this is a case, and I would like you all to just look at the image very briefly. And here's a brief history. It's a 13-year-old girl. She was treated with a shunt since she was 6 months old. She had 3 revisions when she was 3, 5, and 10. But since age 11, she had several revisions. And some of these revisions were even with questionable shunt failure or no documented shunt failure. She continues to have headaches. And the question is what to do about this. Of course, to solve this, we need to know some more about the patient. And we also have to consider which treatment principles will or which ones will not work. And this adheres very closely to what Hal just said. So let's just briefly consider one of the most basic valve types, the Spitz-Holter valve. As many of you will know that valve-bearing shunt treatment was invented in tandem by an engineer and a neurosurgeon in the 1950s. And it's a spring-bearing valve with a compressible spring, which determines opening and closing of the valve. And very basically, this is the general working principle of many still available commercial valves. The way it works is that looking at the right-hand side of the picture, you can see the pressure of the fluid pushing down on the ball, and the ball will then compress the spring, which will then open. And of course, you can easily imagine that the tension of the spring will determine how much force is needed to move the ball and open the valve. Now, looking at the picture to the left, this is sort of a radiator valve, which most of us know. So we can turn up and down the radiator valve. Although
you have to move the slide, Marianne.
What?
The slide, get the slide, next slide.
The left side, so on your left side, you have to move it down and then click on each of those slides because it is not proceeding by itself.
Ah, okay, I'm sorry.
Yeah,
that is yeah, right. So there is something wrong with the way it's presented.
Yes,
yeah.
yes.
Okay, so we'll have to proceed in this way then.
Yes,
yeah.
This is the only way, yeah.
Right. So just repeating, to the right hand of the slide, you have this spring-bearing valve with a ball, and the spring is compressible, and it's quite easy to imagine that with the pressure of the fluid, you can imagine that the tension of the spring will determine how much force there has to be to move the ball and open the valve. Now, to the left-hand side is a radiator valve, and most of us are acquainted with a radiator valve, which you can turn the valve and then you can tighten or loosen the spring. And although the mechanical analogy is not perfect for adjustable valves, it still helps us to visualize in our heads what actually happens. So actually, when you tighten the valve, you make the spring harder. It is more difficult to push the valve open, so it increases the opening pressure for the fluid to come out. If you loosen the valve, less pressure is required to lift up the plate, and the fluid can go through. So the only thing you change by turning the handle is actually the tension of the spring. And once the valve is open, everything else is the same. So the only thing you change by turning the handle is actually how difficult or how easy it is to open the valve, and everything else stays the same. This is important. looking at this curve is the general working principle for a differential pressure valve, which was the kind of valve that we were just looking at. So you can see that in this instance, there is, well, I need to say that you have a flow on the y-axis and you have the driving pressure on the x-axis. And here you can actually see that below 9 millimeters of mercury, the valve is closed. There is no flow through it. So it requires a pressure of, well, 9 or 10 here to open the valve. Once it is open, there is a linear relationship between the flow and the pressure. And the relationship between the pressure and the flow is the inclination of the curve, and the inclination of the curve is the resistance of the system. So here you have the opening pressure, and here you have the relationship between flow and pressure, telling you how much flow will be for a particular driving pressure, and the inclination of the curve tells you the resistance. There is an almost direct analogy to Ohm's law, which many of you will know. So U here would be equivalent to the driving pressure. I, which is the current, would be equivalent to the flow, and R, of course, being the resistance. Right. So all these questions I actually answered in the slide: how to read the opening pressure. What is the driving pressure? Well, the driving pressure is the pressure above the valve minus the pressure below the valve. We'll go into that in details in a little while. When driving pressure increases, well, the flow increases in a proportional manner. And how do I read the resistance? Of course, the inclination of the curve. That is very easy. Now we will look at what happens when we change the opening pressure of a differential pressure valve. So all adjustable valves function according to differential pressure principles. So we already saw this analogy: tightening or loosening the spring tension, more difficult or more easy to compress the spring, and this would change the opening pressure. Now let's look at this. Here we have the curve that we saw before, the functionality curve of the valve with an opening pressure of 10. If we want to increase the opening pressure of the valve, for instance, to counteract over drainage, we could change the opening pressure to 12 or maybe even 16 or 18. And if we do that, we just change the opening pressure, we just slide the functionality curve to the right-hand side. The rest of the system will function exactly the same, and the inclination of the curve is the same, so that once the valve is open, everything else is the same. The resistance is not changed. The only thing that has changed is the opening pressure. Equally, when you reduce the tension of the valve, of the spring, you reduce the opening pressure maybe down to 7 or 4 or maybe even 1. It's easier to open the valve now, but once it is open, it has a functionality curve which is exactly parallel to all the other functionality curves. So once it is open, it stays with the same resistance. Just a minute ago, I was talking about the driving pressure. The driving pressure is the pressure that determines whether the valve opens or not. It's actually easier to understand this if you think of a door, which one person is trying to open, and there's another person at the other side of the door also putting some pressure on this door. Now, whether this door will open or not is, of course, a balance between the force presented by the guy on the right-hand side and the guy on the left-hand side of the door. So if there is no guy on the left-hand side of the door, the guy on the right-hand side of can open it very easily. But if the guy on the left-hand side pushes some pressure, it requires more pressure to open the door. And that is what is meant by the driving pressure, which is the sum of the forces on either side of the door, which will determine whether it opens or not. Why is this important? I will show you now. Let's just imagine we have a patient here. This patient has a valve with an opening pressure of 10 millimeters of mercury. In this case, the patient is lying down, and let's just assume that the pressure on the downside of the valve is 0 millimeters of mercury. It's not an unreasonable assumption, as the CSF axis is actually horizontal in this case, and it's easily assumed that the pressure will be the same along this axis. So let's just say, what is the resulting pressure that we get in the ventricular system in this case? It is an often met assumption that if you put in a valve which opens at 10 millimeters of mercury, then the resulting ICP will be 10 millimeters of mercury. And if you put in a valve with an opening pressure of 8 millimeters of mercury, then you get an ICP of 8 millimeters of mercury. And if you put in a valve of 15 millimeters of mercury opening pressure, then the resulting ICP will be 15. However, that is only true if the downside pressure is 0 millimeters of mercury, according to the door analogy that I just showed you. So let's just deal with that in a little more detail. Now, most patients don't live their lives in the horizontal position all the time. A lot of us spend time in the upright position most of the day. So what happens when you stand up? Well, if you stand up, the shunt tube will be vertical, and the CSF axis will also be vertical. So it's very intuitive to assume that the downside pressure on the valve will decrease. For the sake of argument, let's just say that in the upright position, this person's downside pressure on the valve decreases to minus 20 millimeters of mercury. It now means that the pressure on the outside of the door is minus 20. We still have the valve opening pressure at 10 millimeters of mercury. So the pressure required to open the door is, of course, 10 millimeters of mercury higher than minus 20, which means that the required opening pressure upside will be minus 10. This, of course, means that this person is at risk of overdrainage in the upright position, simply because the downside pressure of the system decreases when he stands up. So let's just assume that he has an adjustable valve. So let's just say we don't like this. So we change the valve opening pressure from 10 to 20. So what happens here? The downside pressure on the valve is still minus 20 when he stands up. We now change the opening pressure of the valve to 20, which means that the pressure required on the inside of the door to open it will be minus 20 plus 20, which is 0 millimeters of mercury upstream. So a pressure intracranially of 0 millimeters of mercury is 20 millimeters of mercury higher than the downside pressure and adequate to open the door. So we got rid of overdrainage here because we have now put this patient in the ballpark of health rules for shunt functionality. In the upright position, you need a pressure between 0 and minus 5. So we achieved that. But let's just let this patient now lie down. Lying down, we again achieve the downside pressure on the system of 0 millimeters of mercury. We now have the opening pressure, which we adjusted to 20. So the resulting pressure to move the door open on the upside will be 0 plus 20, now 20 millimeters of mercury, meaning that when he lies down, it will require a pressure of at least 20 millimeters of mercury to open the valve. So now he has under drainage in a horizontal position. So we paid getting rid of over drainage. We paid off with under drainage in the horizontal position, and this is exactly the way to illustrate why an adjustable valve to counteract over drainage may not be enough in itself. There are other requirements to meet these challenges. So what we learned right now, about halfway through my presentation, is that ICP is not necessarily the same as the valve setting, because the resulting ICP is the sum of the downstream and the upstream pressure and the valve opening pressure. And changing the valve setting will only change the opening pressure. It will not change the resistance or the flow through the system, which is exactly why we end up in this situation, almost like sitting between two chairs with this patient. So returning to our case here. So what should we do in this case? Well, let's assess what is actually happening. She had 3 shunt revisions at some intervals, and then something happened from the age of 11 with the valve, not anything really being wrong with the valve. As Hal said, if you run into continuous problems, it's probably not because the valve is malfunctioning. It's probably because the physiology of the patient and the valve are not a very good match. And of course, this patient has continuous headaches because her dysregulated ICP is not cured with this shunt. So, wow, why does that look like this? Okay, so the shunt is working, but the valve mechanics do not any longer match the patient's need. We can see on the image that there is clearly over drainage, but the patient may actually also have bouts of increased intracranial pressure when she's lying down or sleeping at night, because compliance may be severely reduced by the very small ventricles. So she needs a change of treatment principle. So we need to know the functionality of the valve that she has now. Let's just assume that she had this valve principle with a differential pressure valve with no other additions to it. So what could we actually do? Well, an adjustable valve very probably will not solve the problem in itself for the reasons we saw before, because you can change the opening pressure, and it was very hard to achieve a situation where she has an ideal opening pressure both in the horizontal and in the vertical positions. So you need to add something which will change this. So you can add an anti-gravity device, which we'll go into in a little while, or you could add an Antisiphon. Very briefly, these are devices that kick in once the flow requirements change. So if you stand up, the anti-gravity device will kick in and make it harder for the shunt to open, or the Antisiphon device will kick in and make it harder for the fluid to run through. We'll go into that in a little while. Another option could be to change to a flow regulated valve. That might be an answer, but you'd need to know more about the ICP dynamics of the patient to make sure that this would be correct solution. We'll go into that a little later too. And again, if you have a really difficult situation, it could be a good idea to monitor the ICP to see actually where the patient is and to see how the change in this patient is between lying down and standing up. And this might tell you how much would be required to titrate you away from this overdrainage situation. Oh, wow. So let's go into a little more into overdrainage and antisiphon and siphon and antisiphoning and antigravity. So a siphon effect is actually the effect you see when you stand up and gravity causes a too high flow through the tubing system. So what you actually need is some sort of device which in this situation will reduce the flow or reduce the ease of flow through the system in the upright or hyperflow situation. Very basically, there are two principles in such devices. These principles I call a parallel channeling and serial channeling. I will present or introduce you only to the very, very basic principles according to this way of thinking. But there will be in an additional webinar, the next webinar, I believe there will be more details about how antisiphons function in mechanical details. But you need these very basic principles now to be able to understand what happens in the next webinar. So let's look first at the serial channel. How does that actually work? So there should have been an animation, but because we can't run it as a slideshow, it will be without the animation. So let me just explain to you that when the patient is lying down, there is one door for the guy to open. So there is just the opening pressure of this door. But when the person stands up, another door pops up. So the mechanism functions in a way that when the patient changes from the horizontal to the vertical position, the mechanism of the valve will make this door appear. In the horizontal position, this door is not there. It only appears when the patient stands up. So now this person has to, the imaginary person has to kick up one door, and then he has to kick up an additional door. So what happens with an anti-gravity device is that you add extra opening pressure. And the way the valve knows that it has to pop up an extra door in the vertical position is related to the positioning of this extra valve device, because you have to orient it behind the ear so that it is horizontal in the horizontal position and it is upright in the upright position. And then it is in the correct position to titrate or to know whether it is vertical or horizontal. So it has to correspond to the body axis for the valve sort of to know that. Now turning to the parallel channels. This is instead of a serial principle where you had one door and then the other door, in the parallel channels, you actually have two channels inside the valve. The main channel is wider than the side channel. And when the main channel is open, of course, it is easier for the flow, for the CSF to flow through a channel with a wider bore. But what happens actually when flow increases, then the wider bore channel will be blocked. There is a mechanical functionality in the valve that blocks the wider door, the wider tube when flow increases. So now, instead of being able to run through the wide tube, you have to creep through the tube with a smaller bore. So of course, this tube has a much less resistance compared to this. So typically, antisiphons in parallel channel will increase the resistance of the system by forcing the fluid through a smaller tube. There are several designs of this functionality principle. And as I said before, this will be dealt with in much more detail in the upcoming webinar. One of the other solutions that was presented in the case we just had before was to change maybe to a flow control valve. In order to understand the functionality of the flow control valve, I will introduce you to another case, or rather another two cases. We here have two seemingly identical patients. On the right-hand side, we have a 76-year-old man. He has NPH, and he was implanted with the flow control valve called OSV. On the right-hand side, we also have a 76-year-old man. He also has NPH, and he also received an OSV valve. Our patient to the right, when seen at 3 months follow-up, was actually clinically much worse. And when he was scanned, it was shown that he had bilateral subdural hematomas, and the ventricular system was much, much smaller than prior to treatment. In fact, it was overdrained. So this patient had overdrainage with bilateral subdural hematomas. In contrast, the other man had postoperative improvement, and his scan was unchanged. It's very frequent that the ventricular system volume does not change with shunting of NPH, but the clinical effect can still be there. So why does it actually happen? Why did one patient do so badly, and why did the other patient do so well with the same valve and seemingly the same history? Well, in order to answer this, we need to know more about NPH maybe, but in particular, we need to know more about our patients, and we also need to know something about the functionality of the OSV valve. This is an industrial diagram of a flow control valve. Actually, this industrial flow control valve shows the functionality principle of 3 valves of different sizes, but the way the curve is shaped is the same for all 3 valves. And sometimes it's easier to understand industrial diagrams, and that's why I chose this. So it's actually almost intuitive to see that there are 3 parts or 3 segments of these curves. So let's try and take a closer look at these 3 segments. So you can see actually in this red section, there is, I need to tell you that the flow is on the y-axis, and the pressure or the driving pressure of the valve is on the x-axis. So you can see actually that in this situation, in the red panel, there is 0 flow. It is not until a certain pneumatic pressure that the valve actually opens. So, although it is a flow control or so-called membrane valve, it still has an opening pressure below which there is no flow through the system. So if the driving pressure in the patient is below this opening pressure, then the valve does not do any good. The next phase is the so-called transition phase. And the third phase is the flow control area. You can actually see that in this green area, flow is more or less very constant. So in this area, you can change the pressure as much as you want, but the flow stays the same. So this is a valve that is designed to keep flow regardless of changing pressure. So ideally, this should maintain flow at a certain predetermined value and reduce overdrainage that way. But the problem is the transition phase, because what is happening in the yellow or transition phase area? Well, in this area, actually, we have a situation where there is a linear relationship between the driving pressure and the flow rate. And if you remember a few slides back, a linear relationship between pressure and flow was exactly what we saw in a differential pressure valve. So in the yellow area, before we reach a pressure that where the flow is maintained constant, before we reach that situation, we actually have a differential pressure valve with an opening pressure and a linear relationship between flow and pressure and flow. So here in this yellow area, we actually have a differential pressure valve without any anti-gravity device or without any other antisiphon protection. So we in fact invite this situation to give over drainage risk. So let's try and look at the OSV valve, and please pay attention that here the axes are inverted. The reason why that is so is that this is the way the functionality principle is presented by the manufacturer. So now we have flow here and we have pressure here. And of course we have a green area here where flow is almost independent of pressure, and the flow rate is set at the flow rate which is assumed to be the normal CSF production rate. So this valve is designed to get rid of CSF at a flow rate which matches the production rate. But before we reach the green area, we have a differential pressure area, which is here, and we have below that, we have an opening pressure. So for the OSV valve, the opening pressure is just under 6, and the transition phase ends just under 10. So between about 6 and about 10, we have an unprotected differential pressure valve. Now let's try to apply this to the situation we had with our patients. So the patient who did well with no overdrainage and with unreduced ventricles is probably a patient who has a pressure which puts him in the green flow control area of the valve. Whereas the patient with the bilateral subdural hematomas very probably has an ICP which puts him in the range where the valve does not reach flow control area, but functions in the range of an unprotected differential pressure valve. So looking at the opening, at the pressures indicating the functionality changes of the valve, this patient very probably had a preoperative ICP above 10 millimeters of mercury, putting him in the green range. And this patient here probably had an ICP below 10 millimeters of mercury, putting him in the danger zone of the yellow area. So I have now tried to introduce some basic principles, introduce the differential pressure valve with a case with overdrainage, try to introduce you to what happened to the valve functionality when you change the opening pressure, introduced you to two basic principles of overdrainage protection mechanisms, and introduced you to a basic functionality of a flow control valve. So now the self-test questions and principles will be taken further by the next speaker. Thank you for your attention.
Thank you, Marianne, very much for this very, very informative lecture. And I think that is a lot of information, needed information we could learn from your talk. Now, our good friend and our good teacher and one of the most respected neurosurgeon and very wise man, Andrea Grutenhuis, is going to take over and answer your questions and ask you. So please send any question you may have, and we will answer it. Go ahead, please, Andrea. Floor is yours.
Thank you so much, Ahmed and Hal and Marianne. I think these basics are so important, and it is still surprising for me after 40 years in neurosurgery that this is not common knowledge for neurosurgeon, which is odd, because very often we see that a shunt is done by the youngest of staff or residents, because surgically implanting a shunt is not a very difficult technical issue. The problem is how to choose the right shunt for that individual patient. And we have now seen some of the basic principles, and actually those principles are rather easy to understand, because there are not a lot of differences. Let me share my screen. Let me see where I have this. Yes. Hold Control to select more. Yeah, and then. Okay. Let's see if I there are some technical difficulties. You probably don't see the full screen, isn't it? Because for me it is now.
We see the full screen, but
okay. So you see this the whole screen. If I move it forward, you see it.
No change.
No change. You see, that's the difficulty. Somehow it doesn't work so well. So
actually, Andre, we see the slide sorter. We don't see that.
Yeah. So and now you see it. You see how I changed the slides or not?
Yeah.
Yes.
Yeah.
It is the same with you, Marianne. That
yes, exactly as Marianne.
As it was. So in all those 70 years of having shunts around, as Marianne was so well describing it, there are only actually 2 types of shunts. So the choice is not among the so-called more than 200 different shunts that are on the market. Actually, I think that Professor Aschoff from Heidelberg once even collected more than 260 different shunts that are commercially available on the market in the world. And those shunts had close to 500 different pressure settings. So then, of course, I can imagine that you say, oh my God, what kind of shunt should I use? But you see that 95% of the shunts are differential pressure valves. And the only other type is a flow controlled. And now it comes that in a certain area, range of pressure, that flow controlled valve is simply acting as a differential pressure valve. So this is important to get in your minds. That's very easy. But I hope you did actually do self-assessment and answer these questions, that there are, well, hundreds of shunt valves available from commercial suppliers, but there are only a few main types. And that's a correct statement. That statement is correct because there are only two valves. And the very most type of valve are differential pressure. That means valves that react to the pressure inside the ventricle, where you have a ventricle catheter, which is actually vertically to the skull, and then connecting to either the atrium, which is not common nowadays anymore, or the abdomen. where there is different values depending on different situations. As we have seen, if you lay down, that's 0. If you're on the upright, your abdominal pressure is low, maybe even minus. But now it comes in obese patients, it can be even higher. So sometimes in obese patients, we think we put in a differential pressure valve, it simply will not open because the abdominal pressure is higher. So at the end of the equation, that pressure is too high. And we should take that into calculation when we have to deal with any kind of situation like infants with an open fontanelle, in adults with normal pressure or intracranial hypertension in an obese patient. All this, we think we implant a shunt. And technically, implanting the shunt again is not a very difficult procedure. I mean, it still does need to be done very precisely and carefully to avoid a lot of other complications. But from the physics, there are only 2 types: differential pressure. That's what you should think. And there is flow regulated, but only at a certain amount of pressure, it really works as flow regulated. So this is what you should know. Then we had the second question in the self-assessment. We have programmable valves. And I know that some people like them very much. They, you have the possibility to change sometimes, well, not even doing surgery, with a magnet on the outside, you change the opening pressure. And by doing so, the question was, do you change, you increase, if you increase the opening pressure, you increase the resistance. I hope you have listened carefully to what Professor Euler was telling you, because then you answered correctly that this is not correct, this statement. Because please remember that, that slide. Opening pressure is just this curve that is just moving from left to side, but the slope of the curve, the slope is the resistance, doesn't change. Resistance change would be a lower slope or a steeper slope. That is resistance. Resistance to the fluid going through it. No, opening pressure is only when it will open. So when this door will open. So it's behind the door, is one little child, or there are 2 adults, or 10 adults again pushing against the door before you can open it. That is opening pressure. That is not resistance to the flow itself. So how much, when it finally opens, how much can go through? That is very essential in what we have to deal with, over drainage or under drainage, because that is very much decided by resistance, not opening pressure by itself. So please remember, resistance is not affected by any kind of adjustment of the opening pressure. It's only the moment the flow starts to go, the moment that fluid can go through the system. That's the opening pressure, not how difficult it is for that fluid to go through. And that is also what is in that next question on the anti-gravity. And we have gravitational shunts now. So anti-gravity means when you are in horizontal position, then a little bit upward and sitting, and then vertical. And they counteract over drainage by increasing the opening pressure. That is what is gravitational about, and that's indeed correct. But please, again, I have to say, that is what anti-gravitational does. In horizontal, it's that way. It changes the opening pressure again. So it's the moment it opens to the fluid wanting to go through. But the moment it opens, the resistance is the same. There is nothing different by that. And therefore it was that then the other question, that anti-siphon devices counteract over drainage, because this is the reason we use anti-siphon devices, by increasing that opening pressure. Well, now you know the answer. That's not correct, because the anti-siphon, not anti-gravitational, anti-siphon device is developed to increase the resistance and not the opening pressure. I always tell my residents, it's like you have a big mountain and there is a wonderful big tunnel through that mountain to have all the traffic going through. It's very easy because it's a huge tunnel and a lot of traffic can go through. And then we close that tunnel and the whole traffic has to go again through that little narrow road over the mountain to get to the final destination. That is increasing resistance. So the flow itself decreases. It has more difficulty to go through the system. So that does not depend on opening pressure. And that is anti-siphon. That's the difference between anti-siphon and anti-gravitational. You think it is complex? Well, please join us for our next webinar, because we will have a great guest speaker, which is Christoph Mietke. And the Mietke valve was the first to develop anti-gravitational valves. He will address, and the whole webinar is about anti-gravitational and anti-siphon devices, to give you the understanding, the physical understanding of what you do when you put either a shunt assistant or anti-siphon device in between your valves, if you where the position is, the vertical position according to the ventricular catheter, according to horizontal or vertical position. All this will be addressed in our next webinar. But we hope that you have already got a glimpse on these physics of hydrocephalus valves. So the final question was that there is only one flow regulated valve. It's the Orbis Sigma valve. There was the first one, but now on the market is the number 2, the second one. It's the only flow regulated valve. And it has an opening pressure. So commercially, if you have it, its opening pressure is 6 millimeters of mercury, which is about 9 centimeters of water. But when it opens, then it maintains the steady flow. If you listen carefully, you know that that's a tricky one, but stating it that way, it is incorrect, because actually between 6 and 10 millimeters of mercury, so that's 9 to about 13, 14 centimeters of water, which is more or less a normal intracranial pressure, it actually acts as a differential valve. Please, you should remember that curve. It's first flat. It doesn't open because it has an opening pressure. Then initially, it's very steep. It has that same steep line of connection between pressure and flow. That's differential pressure. And only at higher levels, then the flow becomes continuous. Then it is really flow regulated. So the driving force for the orbis sigma needs to be more than 10 millimeters of mercury. In conclusion, and I think also in answering some of the questions that I saw in the Q&A, yes, I think we should much more look to the individual dynamics of our patients, understanding why a shunt worked well for 8 years in a child and then the child gets problems. We should not think about the shunt, we should think about how dynamics of that child had changed. The physiology of a growing child has changed. This makes shunting hydrocephalus in children from young age, neonatal age, infantile hydrocephalus, up to adult age, such a challenging procedure. But that actually will be our third webinar, the other webinar, where we will focus on case-based studies and show you cases on how to decide what to do, what kind of shunt to choose in certain situations. So it is simply, in neonates, oh, they are little children, it's all soft, the skull, so we need a very low pressure. That's wrong. We will come to that. We will bring you to make the proper decision to treat hydrocephalus with shunts. You probably know that I'm also a very big fan of endoscopic surface tracheostomy. I mean, endoscopy was one big part of my career, but shunts are still the mainstream of treating most cases of hydrocephalus. And we as neurosurgeons, we should understand physics of the shunts, and you have already heard this webinar about the basics, and we have to learn about the physics of our patients. And that is what I wanted to add. Thank you so much, Ahmed, please. I stop share, wait. Yeah. And you are muted still.
Yeah. Thank you very much, Andrea. It's great as usual from you. Now the floor is open for our attendees and our guests to ask any questions. We will be very glad to answer any question you may have.
The only question I see is actually a greeting. Assalamu alaikum.
Well,
also to you all. Assalamu alaikum.
About understanding the mechanism of the shunt, if I have, in this case, that is, I may have few questions to ask. Maybe this is what stimulate our trainees and our attendee and our colleagues to ask a question. So, Marianne, do you think that is the diameter of the tube has any rule for controlling the flow of the shunt? For example, if you put a shunt for, say, medium pressure, you use it for some time. And can you use a tube in the same diameter or wider diameter, or you think this is going to change as you are talking about, that is the distal pressure, and this is it changes the whole mechanism or whole function of the shunt in the body?
Oh, yeah, you would definitely change the functionality of the system by changing the tube diameter, because that would change the resistance of the entire system. So if you imagine that you put in a tube with a smaller diameter, it would be like having an antisiphon device, but the antisiphon device would also be operational in conditions with a lower flow or with the patient in the horizontal position, because the resistance you chose by the smaller diameter would be the same regardless of the patient position. So it would be like just increasing the resistance of this of the system in any situation.
Thank you very much. This is very clear, because there is a habit actually for that is the people who they get the shunt to get shortened by any reason, they keep the valve and it changes the tube, the distal tube, and sometimes this is not right.
But you know that in very early times, many hydrocephalus shunting systems were only consisting not of having a kind of differential pressure valve inside. It was calculated by the internal resistance of the tubing, which can be very long. And if you have the commercial, it's 80 centimeters or so. Try to put that in the abdomen of a neonate. That's quite a thing to do. But also, you know that, you still remember that. That's the size of the slit on the distal valve. The famous Raimondi valve was just a tubing with a slit, and it depends on the size of that slit how much resistance there was. And that is what people are asking now in the Q&A is also about, well, there are some questions about addressing negative and low pressure hydrocephalus after meningitis or blooding. We will come to that in our third webinar, because then we will show some cases, because then we also have to address compliance of the brain. After trauma, after bleedings, there is a change of compliance. So again, the physics, the physiology, the physics of the patients is changing. The way the brain can react to what is happening is different. And and some people ask, how choose the valve when they change the valve when maybe the ventricles are not, they still remain dilated. I only have to say, I personally really want to warn against a kind of cosmetic surgery in hydrocephalus to make looking ventricles nice on a scan. This is what our pediatricians want us to do, looking normal. But we know that also from third ventriculostomy that the ventricles are not maybe normal sized, but that is not, it is about the dynamics that that will improve, yes or no. It's not trying to get ventricles smaller or, oh, too small, oh, a little bit larger, so until it is not, that is not the issue. We really should think about and forget about shunting hydrocephalus is equal to trying to get normal ventricles on a CT scan. That's not the same.
That is very important issue. It's not that is the right treatment of hydrocephalus, not treatment of an image. It's the treatment of the patient.
Exactly.
So you don't look for the size of the ventricles.
No, and this is what we now said. We are treating a problem, and this was so wonderfully. I mean, it's amazing to see that it was possible in just 50 minutes for Hal to explain the whole. CSF dynamics. I mean, most of us as young neurosurgeons, as residents, we just learned a little bit during medical school about CSF dynamics, but he explained it was so easily to understand where it can go wrong and how we should look into it. What is hydrocephalus actually? And also understanding this is an active condition of changing of these dynamics. And since the normal condition is all areas where CSF is present in the human, they are usually connected in the normal situation. So we should look also to that. Are those CSF compartments connected. Because if we start to drain, let's say, the ventricles, and they are not connected to all the other parts of it, we only drain a little part of the CSF. So a little part of the problem. We are not dealing with the whole problem. And these are the basics. And these two, I hope really that people will have the possibility to look again to the YouTube recording of this webinar and just listen to 15 minutes of basics understanding of what is CSF dynamics. What is this fluid about? What is going on there in our brain and spinal cord? Why do we have this fluid, and what's the function? And what can go wrong? And then we have, if we have a shunt, try to understand that it's around for 70 years and still many surgeons insert it and have no clue. I personally know from my residents and staff, nobody ever looked into the manual of the manufacturer to the principles of that shunt, and they are different. They are different.
Yeah. We have few questions. One from Vijay Palasingam. He says that is, will you be addressing negative pressure hydrocephalus, which occurred to us after meningitis?
No,
and
no,
there's
we
another
have already
quickly
answered that.
Okay,
yeah.
And there is another question from Martin. Low pressure, low versus very low pressure valves in neonates.
This will be something we will address later on when we, the next one is on Antisiphon devices. So it's more the second part of valve physics. But then we will have some of these issues on neonatal hydrocephalus in toddlers, in post-traumatic, in post-hemorrhagic, post-infectious, in normal pressure, and so on. We will come to that. So this is not a part of this talk.
There is another question which is interesting as well from Bassam Dobes. He says, is there any documented evidence regarding the amount of resistance reduction versus length of shortening the shunt tube?
No, the length, I mean, physically you can measure that, but it is actually, if you look to that, if you have a 1 meter shunt catheter, a distal catheter, versus 50 centimeters, it's a very, very limited change of resistance. So it is, if you really say that shortening the full length of the commercially available catheter does not change a lot of the resistance.
Hal wants to say something.
I do, and I know that we're going to be dealing with this in the third, but I think it's really important to say to disdain use of very low pressure valves in infants. You're going to end up with a too small a head. Yeah, you're going to have a very, very thick skull, and it's going to make it much more difficult. We have to realize exactly what Andre said. It's really the size of the brain and not the size of the ventricle that really matters. And just don't look for small ventricles. That's a terrible thing. Want to have normal ventricles. And if you use low pressure, really low pressure valves, I think it's really important to just not do that. Just sort of throw away your low pressure valves unless it's specifically what you've already proven to be able to get an effect that you need. I think that what happens in a newborn who's treated with a low pressure valve, you're going to have a high incidence of PRs later because of cephalocranial disproportion. You're going to have extraordinarily thick skulls, and they will have much more difficulty. So Aim for just a little bit bigger than normal, I think, is what would be if you could really fix it. And trying to get people to do to measure the size of the brain, and the work of Ben Worf and that group have sort of shown that we're too want too small ventricles. We should have, it's not the size of the ventricles really, is the size of the brain that really matters. And I just think that while we're going to talk in much detail about making how you do shunts, but I think that low pressure shunts in an infant is going to make it more difficult for the life of that child. And I think that was an important thing that I think needed to be said. Thank you.
Thank you very much. This is really a very, very important message to remember. Because once, yes, you can have, some people get satisfied that the shunt is working, getting small, but this is something happened now. But look for this patient, a few years later, he would develop a lot of problems. And then there are, there's a question for Marianne. Please ask of overdrainage of the patient. There is a Professor Yolar described an increased risk of overdrainage of patient implanted with the flow regulated valve when their ICP places them in different pressure stages of the orbis sigma valve dynamics. But in this stage, the flow is also lower than in the flow regulating stage. Wouldn't the decreased flow in the initial phase also reduces the risk of overdrainage?
Oh, I have to read that question in order to answer it. So where did you find that?
This is anonymous attendee.
In the Q&A. So if you
Yes, I'm out in the Q&A now.
Yeah, but it is an anonymous.
One of the very
there we
beginning.
go. Yes.
Okay, there you see it. Yes.
There you go. Describe an increased risk of overdrainage for patients with a flow regulated valve when the ICP places in differential pressure. But in this stage, the flow is also lower than in the flow regulation stage. Well, not necessarily, because you can't be sure what the downstream pressure actually is. And when the overdrainage situation for these patients is probably not when they are lying down. The overdrainage situation is probably created when they stand up. And most patients are upright 2/3 of a 24-hour cycle. So they are only in the no overdrainage risk zone when they're sleeping and lying down. So when they stand up and the downstream pressure decreases, the upstream pressure in the low range ICP will still be enough to keep the valve open when they stand up, and for the CSF to flow through almost as if it were a passive valveless tube.
There is another question to everyone, maybe Marianne first, from Moses. When he say, hi, when we look into papers on shunt complication, we will find much higher under drainage rate than over drainage rate. How to explain that? Is that because people, for safe reason, tend to adjust the valve to higher pressure setting?
No, I actually disagree with that statement. I don't know what kind of literature he is reading, but over drainage in literature is a much bigger problem than under drainage. Well, and we have seen, if you see under drainage, it's actually you see a higher valve setting could be well done in let's say in the upright position, but then under drainage in the lying down position. So, but I don't know where the literature comes from that he is referring to, but as far as I know, under drainage is far bigger problem.
Can I make a comment?
Yes.
Please,
actually, it's a lot easier to understand and to deal with under drainage. under drainage is a blocked shunt or a shunt with a too high opening pressure. So that is extremely easy. Everybody understands it, and it's easy to deal with. Over drainage, on the other hand, is a much more difficult issue. It's more difficult to understand physiologically, and very often it is unrecognized, particularly in the initial stages before compliance has been completely emptied out of the system. And symptoms are overlooked and maybe in the beginning not so pronounced. Even looking for a consensus of the definition of overdrainage. We actually looked through the literature to try and do a review on the definition and occurrence of overdrainage, and it turned out to be extremely difficult to do a meta-analysis, because the definitions of overdrainage were so varying between different papers. So that is one of the reasons, is that we don't have a good definition of overdrainage. The overdrainage situation in NPH with subdural hematomas is different from the pediatric overdrainage system with a slit valve, slit ventricle syndrome. And we're just too, shall we say, too ignorant to ask about the initial stages of overdrainage and remedy them before they become a real problem. This was actually why I chose the first case of the 11-year-old girl, because this should have been picked up when she was maybe 7 or 8, instead of after 8 shunt revisions when she was 11 or 12.
Okay, there are also a few questions. Say one question, the last one here, say, how would you approach young patient with recurrent under drainage and over drainage in the same patient, even after minimum adjustment to the valve? I can't understand clearly what he wants to say.
No, I think that what he means is indeed that adjustments, that means adjustments of the opening pressure.
Yeah.
We have seen that in that particular situation, we have this odd balance of having under drainage in a higher setting, because to avoid over drainage in upright position, we have under drainage in the supine position. So at night they under drain, and during the day they just are fine, and a little bit they either over drain or not. So that means the approach of that would be really a so-called parallel increase of resistance. That means an antisiphon. That means that you have to increase the resistance in the whole system and not only adjust opening pressure, because this will not change the situation of the patient.
Yeah. Yes,
I think it's time to, the importance of the ventricle doesn't change if the CSF and the pressure in the ventricle and pressure in cortical subarachnoid space are the same. So if it's possible, the patient that you've just talked about, when the ventricles are big, you should at least try an endoscopic third ventriculostomy. Then you will not have that constant up and down and accordion
Also,
effect. So at least, and sometimes it's not possible, but I think that problem is very difficult to deal with. And generally the best way to deal with it is to do it when the ventricles are large, to do a third ventriculostomy.
yeah. Actually, there's a question, I think was raised or deleted by me, the one who wrote it, but I'm going to ask this question because actually we are as a group discussed it before, and because of the importance of it, I will, and I hope that our colleague who are kindly wrote the question and deleted it, excuse me, but it's not a personal, but the subject is important. He said, so the meaning of what he said exactly, so medium pressure should be considered in all cases of units. So we thought about the dangers of the habit of using medium pressure. And we talked about there are some clinics, some in different countries, especially low-income countries, they have only one valve, low pressure, medium pressure valve. And this can cause really disasters, because this is on the long run, it is, as we have pointed, and Marianne, can cause a lot of problems. And so it is important to choose the right valve for the right individual or the right patient. Shunt is not a treatment of small event or one disease. It is something to stay with the patient for the life, stage by stage. So we have to consider it all the time. So thanks for the asking about the medium pressure. And I will, if I know Marianne and Andy, as they were very much against that habit to use medium pressure in every patient. If they want to emphasize on that point, because I know it is used in many places.
Well, if I can answer,
Yes.
I mean, typically, if you choose medium pressure, it is, the fact is, you have no idea why you would use any kind of valve. And then the medium is the middle way. And typically the middle way is then something that you would simply choose. The fact is that it does not reflect the need of that patient. So you have not given it any thought of what would that specific patient, being it a neonate, or being it a toddler, or being it a 70-year-old with an MPH, you have not given it a choice, a thought. You should, first of all, think what is wrong with why this patient has a hydrocephalus. So what is going on with the CSF dynamics? What's the reason? How can we deal with that? And actually in neonates, as during our rehearsal, I told you that one of the issues that during my training period, it was typically always said, neonates put in a very low pressure. If it is a young child, put in a low pressure. If it is an adult, put in a medium pressure. That reflects the fact that people have no idea about the dynamics of the patient and the dynamics and the physics of valves. So we should really try to work out a kind of individual approach to our patients before we, and also, I mean, I understand that there are hospitals say, we have a preferred commercial supplier. We always use the Pudens higher Schulter, or we always use the Spitz Holter. I specifically use the older types, but you have a specific, but even there you have some choices. And typically, if it is the medium, it's the I don't know choice.
Okay. Marianne, she wants to make
a comment. I have a small comment. Remember that if you put in a medium pressure valve, that does not mean that you obtain a medium pressure ICP, because the pressure you obtain is as the result of the driving pressure across the valve and the valve opening pressure. So even if you implant a medium pressure valve, it is very probable that in the upright position, you will still have over drainage. And then if you put in a high pressure valve, you probably get rid of the over drainage in the upright position, but then you have under drainage in the horizontal position. In my mind, one of the most important principles, two of the most important principles is to obtain a balanced ICP between compartments If they're not connected, you must connect them, and you must obtain the same balanced pressure between them. The other basic principle is that you must, for all costs, avoid over drainage, because if you get into a situation where it's become chronic, it's almost impossible to get rid of, because you ruin the compliance of that patient permanently. So be aware of over drainage. Never put in any medium or high or low pressure without a serious consideration of over drainage protection, whether you use an anti-gravity device, which you can adjust or not adjust, or whether you use an antisiphoning. I would, never is a big word, but I would really be very reluctant to put in a differential pressure valve, regardless of the opening pressure, without considering the serious risk of over drainage.
Thank you very much. I hope the message gets through to everyone. Maybe this is the last question. There is a very smart question from Maria Laura Lefita. She says, do you think that the anatomical site placement of proximal catheter can influence on the resistance versus produce some degree of malfunction of the system?
No,
She's talking about the proximal or ventricular placement of the shunt. Is it frontal or occipital, or is the body of the ventricles?
No, if the conditions are anatomically connected, that doesn't mean anything, but you must of course be accurate about the placement. She also asks whether it has any implication for complications. And if you place ventricular catheters inaccurately, so that they have wall contact or the holes are partly embodied in tissue, then they become occluded earlier. And actually the shunt durability or shunt survival is affected by malplacement of ventricular shunts. But I can't see that the hydrobiomechanical functionality of the system would be changed by the way you place the ventricular catheter.
No,
Unless,
thank you.
I agree with that. That's because the if you place a catheter anywhere, the pressure that is inside the ventricles will pass through that catheter no matter where you place it. So it's decided by the valve system. The valve system is the essential part. We will come to the antisiphon anti-gravitational parts, because there sometimes it is very important to place them in a correct vertical way according to the tubing system, because it acts based on the position. But we will come to the in the next webinar.
Okay.
So
actually,
the second part of trying to understand shunt principles, and that was one of the issues that we had for this webinar. First, starting with the CSF, and second with the shunt principles in general, and we come to the details later on.
Yeah, well, I think we have to come to the end of this very informative, enjoyable webinar, and successful, hopefully. And we would love really to hear a feedback from all our audience, or our attendees, and tell us what they would like to hear from the next webinar, and tell us how can we improve our job, because our aim in the end is to pass the message and informations and knowledge to everyone. So we come to the home take message. So Marianne, if you please, can you give home take message to everyone?
Absolutely. I just have to try and find it. I think there we are. Sure.
Yeah.
Can this be seen?
Yes.
Yes.
Yes, and I won't put it into the slideshow, because I'll just ruin it.
It doesn't work.
So take home messages that, as said 100 times before, valves are either differential pressure or flow control. These are the two general principles. Over drainage can be avoided or treated by an anti-gravity device, which is a serial pressure principle, which will add additional opening pressure. or by an Antisiphon device, which is a parallel principle, which will add resistance, or by implanting a flow control valve, but you must be sure that the patient's pressure puts him in a driving pressure that is in the green flow control area. Match the functional principles of the valve to the patient characteristics. Know as much as you can about the patient characteristics and then choose the valve accordingly. What is known and assumed about RCP control requirements for this particular patient, and you can't assume that the requirement for ICP control and dynamics are the same for all patients. How well do you actually know the functionality principle of the valve that you use, the preferred valve of your department? Did you actually look at the functional profile in the manual, or did you just throw it away like this guy? Do you know if that the valve that you use, if it is a differential pressure valve or if it is a flow control valve? Do you know if it has an Antisiphon or device or an anti-gravity device implanted? Did you look at the functionality curves in the manual? You probably have a second and third choice of valves in your department as an alternative if a patient doesn't do well with their first principle. Do you actually know that the functionality principle of your second choice is different from your first choice? Because if it's not different from the first choice, then you put the same treatment principle in the patient for the second time and you end up with the same result. So make sure that the principles that you use, if the valve doesn't serve the patient well, for instance, if you have an implanted shunt and a patient who doesn't do well, you do the revision, you find out that the valve is actually working, then it is not logical to put in the same valve or a valve that is very similar. You must change principle. And in order to change principle, you must know the functionality principles. So if you have a third choice, that applies, of course, too. So I can only stress very, very strongly, look at the manual, look at the functionality principles, familiarize yourself at least with the first choice in your department. Thank you.
Thank you very much, Marianne. And now, Hal, if we would like to have the last say or last statement, home take message, so everyone will remember it.
Just remember, it's the patient's fault, not the valve's fault. No, it's really important to realize that what you're going to do is going to have to work for the rest of this person's life, and that you can't give up, and that you need to realize that what Marianne said, you don't keep doing the same thing over and over again and expect a different result. You have to think outside the box, and you have to try to understand the patient better. One of the things I would have liked to have said is that you in Europe have the opportunity to use the implantable pressure monitors, and I wish that we could do that in the United States, because it would make our ability to do the right thing to the patient so much easier. And thank you for all being here. And I've learned a lot, and I'm looking forward to the future ones.
Thank you very much. Thank you, Marianne. Thank you, Andrea. Thank you for all the attendees for this meeting. We had a wonderful time. And before we leave, I would like to announce that the second webinar will be in May 11. It is already booked in EANS calendar. We wish to have it earlier than this, but this is the nearest time we could have. And this is May 11. In the same time, we will have the second webinar. It will be the second part about the shunt function and shunt mechanics. And this is advanced in the shunt to all the problem which we mentioned. And then we will have the third webinar maybe in June. And this will be case-based management or case-based discussions. and then we will go ahead. Thank you very much. Again, please, before I leave, that is all attendees, please write to us through EANS and tell us your feedback. And again, thanks, Hal. We always learn from you. Thanks, Marianne. We always learn and enjoy listening to you. And thanks very much, Andrea. You are great, as usual. Thank you very much, and see you again.
It has
next
been
webinar.
great fun to join you all.
Thank you.
Well done, team. God bless you. Wonderful.
Thank you.
Thank you, Mansour, for organizing it all. And Anna, thank you.
Yeah.
It was
Yeah, we have to thank Mansour very much, and Anna. Without them, we wouldn't have such a simple
lovely
webinar.
topic. Yeah, we will go ahead with it. Perfect. See you all.
See you.
Bye-bye.
Bye-bye.